Welcome to The Learner, and, well, really, to anyone joining us today who is ready to question things we've been told are just permanent.
Right, because for so long we've had this quiet clinical expectation about major physical changes.
Exactly, like with childbirth or menopause, it's always been this idea that we just have to accept the losses, you
Yeah,
know?
like fine lines appearing, joints aching, and this is a big one, sexual function inevitably changing.
Right, becoming less sensitive, less vibrant. For decades, the medical consensus basically treated that as a one-way street of biological decline.
It really did. But today, we're looking at this whole landscape of regenerative medicine that suggests that one-way street is actually, well, reversible.
Which is a profound shift in how we think about aging.
It is. I mean, we are moving away from just managing symptoms and looking directly at tissue regeneration,
Hmm.
like utilizing the body's own raw materials to repair that localized degradation.
And that brings us right to the core mission of today's deep dive. We are exploring a question that honestly sounds kind of like science fiction, but it's happening in clinics globally right now.
It really is everywhere now.
So the question is, can the O shot or the orgasm shot actually improve clitoral sensation?
It's a massive question.
Yeah,
And to answer it, we really have to synthesize a lot of complex data.
right. We've got a thick stack of sources today. We're pulling from clinical reviews in the Journal of Sexual Medicine, a major randomized trial from obstetrics and gynecology.
Also known as the Green Journal, which is huge in this field.
Yeah, exactly. Plus, we're looking at literature from aesthetic wellness clinics, and even, surprisingly, a World Bank policy note on global surgical trends.
I know bringing in macroeconomics to answer something so deeply personal and physiological is, well, it's a fascinating cross-section of data.
It really is. So,
Right.
to figure out if this actually works, we first have to isolate what is being put into the body.
Right, because the O-shot isn't like a synthetic filler. And it's not some pharmaceutical compound either.
No, it relies entirely on platelet-rich plasma, or PRP, which is an autologous treatment, right? Meaning it comes from you.
Exactly. The process is they draw the patient's blood, spin it down in a centrifuge, and isolate the plasma to get this incredibly dense concentration of alpha granules.
Okay, so alpha granules. What are those exactly?
So those alpha granules are the payload. When we isolate the plasma, we're concentrating platelets at levels that are far above normal baseline blood.
Right.
And platelets are loaded with these highly potent proteins called growth factors. When they're deployed, these proteins basically dictate cellular behavior.
Okay, because in older biology classes, I remember we used to talk about platelets as just the body's, like, repair crew.
Yeah, the scab formers.
Exactly. You scrape your knee, they form a scab. But reading the literature for this deep dive, a much better analogy for this concentrated PRP seems to be thinking of it like a localized software update for dormant cells.
Oh, I like that, a software update.
Yeah, because you're taking the raw biological code that tells tissue to heal, distilling it into this high-octane fuel, and injecting it directly into the clitoris and anterior vaginal wall to, reboot the system.
The software update analogy is actually highly accurate for the biochemistry here. When you inject that concentrated serum, you're introducing massive amounts of specific growth factors.
Like which ones?
Well, mainly vascular endothelial growth factor, or VEGF, alongside platelet-derived growth factor and transforming growth factor beta.
Okay, lots of acronyms.
Right, but basically, these specific growth factors act as signaling molecules. They bind to the receptors on the dormant or aging cells in the vaginal tissue and command them to initiate a regenerative cascade.
So they're literally giving the cells new instructions.
Exactly.
And when those growth factors hit the tissue, the literature outlines a really specific three-pronged response,
Yes, the first part of that cascade is angiogenesis.
which means the formation of entirely new blood vessel networks, right?
Exactly. And for the clitoris, which is an erectile organ, an expanded vascular network means a massive increase in blood flow.
Which obviously leads to better engorgement and natural lubrication.
Right. And then the second part is that these proteins stimulate the repair of the sensory nerve endings.
Which is crucial since those are the primary conduits for detecting touch, vibration, and pleasure.
Exactly. And the third piece of the cascade is fibroblast activation.
Okay, explain fibroblasts for us.
So the growth factors signal the fibroblasts to ramp up the production of type 1 collagen and elastin.
Oh, okay. Like what keeps skin looking plump?
Right, and this is critical because as estrogen levels drop, like during perimenopause and menopause, the mucosal lining of the vaginal wall thins out.
It loses its elasticity and gets really fragile.
Exactly. So the newly produced collagen matrix physically thickens the tissue, literally reversing that structural atrophy.
Okay, so the blueprint makes total biological sense. You rebuild the blood supply, restore the nerve network, and reinforce the structural integrity of the tissue.
It's a very elegant biological mechanism.
It is, but, theoretical biology has a habit of falling apart in clinical practice. A cellular blueprint doesn't guarantee the house actually gets built.
Right, which leads us to the data. Does the clinical evidence prove that women actually experience improved sensation?
Yeah, what are the studies actually showing?
Well, the early clinical evidence strongly supports the biological theory. There's a 2021 systematic review published in the Journal of Sexual Medicine that looked at this.
And they analyzed the available trials on PRP for female sexual dysfunction, right?
Yes, they used the Female Sexual Function Index,
Yeah.
or FSFI, which is a highly validated clinical questionnaire.
Okay, and what did they find?
The researchers found that PRP injections yielded statistically significant improvements across multiple domains of the FSFI.
Like which domains specifically?
Specifically, patients reported major increases in arousal metrics, the volume of natural lubrication, and the frequency and intensity of orgasm.
Okay, but playing devil's advocate here, reading through the regulatory landscape, there is a massive disconnect.
There really is.
Because if the systematic reviews are showing significant improvements in arousal and orgasm, and the biochemistry is sound, why is this still considered an off-label or investigational procedure?
That's the big question.
I mean, major medical bodies like the NHS and the Royal College of Obstetricians and Gynecologists are still officially advising caution. It feels like they're looking at the exact same data but arriving at a completely different conclusion.
Well, their hesitation isn't necessarily a denial of the biological mechanism. It's more of a critique of the early trial designs.
Because the sample sizes were too small.
Exactly. Regulatory bodies demand really rigorous, double-blind, randomized controlled trials before adopting anything as a standard of care. Early PRP studies were plagued by small sample sizes and, crucially, they lacked placebo controls.
Ah, right. And in sexual health, controlling for the placebo effect is notoriously difficult.
It's incredibly difficult. The brain is the largest sexual organ. If a patient believes a highly clinical, medicalized injection is going to enhance their sensitivity.
The psychological anticipation alone can manifest as a measurable physical improvement.
Exactly. So the NHS and others are essentially saying, prove to us this is the growth factors building new capillaries and not just a very powerful psychosomatic response.
Okay, that makes sense. So has anyone actually proven it yet?
Yes, actually. That demand for higher tier evidence is finally being met. A highly significant randomized controlled trial was recently published in Obstetrics and Gynecology.
The Green Journal study.
Right. The study, led by Clark and colleagues, specifically took women diagnosed with female sexual interest and arousal disorder and split them into two groups.
Okay.
One group received the actual PRP injection, and the control group received a placebo injection of normal saline.
Which totally controls for the psychological anticipation of getting the shot. They both went through the same procedure.
Precisely. And the results were really clear. At the 12 and 24-week follow-ups, the women treated with the actual PRP demonstrated vastly superior improvements in their FSFI scores compared to the saline group.
Wow. So it confirmed the regenerative tissue response was biological, not just psychological.
Yes, and importantly, they reported no serious adverse events.
That's huge. And this trial is heavily cited as a major validation. But digging into the sources, there's a really intense dispute about the specific methodology used by those researchers.
Yes, the protocol dispute. It's a massive point of contention.
Right, because Dr. Charles Runels, the physician who invented the trademarked O-shot protocol back in 2014, he reviewed this Green Journal study and basically pointed out what he considers a fundamental anatomical flaw.
Yeah, the dispute centers entirely on the injection sites. The researchers in the Green Journal study administered the PRP only into the anterior vaginal wall.
Wait, they deliberately bypassed the clitoris entirely.
They did it.
Which seems completely counterintuitive if the whole goal is to measure improvements in arousal and orgasm.
Dr. Rudels certainly thinks so. He argues that while injecting the vaginal wall does provide measurable benefits, skipping the clitoris ignores the primary node of the female sexual response cycle.
Right, because we know from recent anatomical mapping that the clitoris has upwards of 10,000 nerve fibers.
Exactly. And it's not just a surface structure. The bulbs and crura of the clitoris wrap internally around the anterior vaginal wall.
So that internal anatomy is key to the whole thing.
It is. The trademarked O-shot protocol dictates a very precise methodology for activating the platelets and mandates injecting both the clitoris and the vaginal wall.
So by doing both, the growth factors saturate the entire interconnected neurovascular network.
Exactly. Dr. Runel's argument is that the Green Journal proved a generic partial PRP treatment works, but it completely fails to capture the maximized efficacy of the full targeted protocol.
Wow, it just perfectly illustrates why standardizing protocols in regenerative medicine is so incredibly difficult right now.
It really is a moving target.
But okay, putting the trial mechanics aside for a second, there's a massive elephant in the room here.
The need.
Yes. We are talking about isolating plasma and taking a needle to a region with 10,000 localized nerve endings. I mean, the prospect of injecting the clitoris sounds like a highly invasive, agonizing surgical event.
The psychological barrier to entry is undeniably high based on that description alone. But the clinical reality of the procedure is vastly different.
Okay, how so? Because I think a lot of people listening are just crossing their legs right now.
Understandably. But to understand why it's not agonizing, we actually have to pull in that macroeconomic data from the World Bank policy note on global surgical trends.
Right. I was wondering when we'd get to this. This was the most unexpected source in the stack. How does a global financial institution's data on healthcare economics explain why getting a needle there isn't painful?
Well, the World Bank note details the global transition toward ambulatory surgical centers. It's the day surgery revolution.
Okay, break that down for us.
Historically, the risk of hospital-acquired infections, combined with the volatility of general anesthesia, meant that even minor procedures required full inpatient hospital stays.
Which obviously created massive overhead costs for healthcare systems.
Exactly. So over the last few decades, the medical industry developed specific technologies to move patients out of hospital beds and into outpatient clinics.
To vastly reduce costs and, democratize access to care.
Right. And the primary drivers of that shift were the development of ultra-fast-acting localized anesthetics and rigorous sterile techniques.
And the O-shot is basically the apex of this day surgery trend.
It really is. The entire appointment, from the blood draw to the injection, takes roughly 45 minutes in a standard exam room.
Wow, so no operating room?
No. And providers utilize highly specialized pharmaceutical-grade topical numbing compounds. Usually it's a dense formulation of lidocaine, tetracaine, and bupivacaine.
And when applied to the mucosal tissue, that compound permeates the surface incredibly quickly, right?
Yes. Within 20 minutes, the area is entirely desensitized. The clinic data shows that when patients are asked to rate their pain during the actual injection on a scale of 1 to 10,
Well, let me guess it's surprisingly low.
the overwhelming majority rate is a 2.
A2. That's it.
Yeah, it's mostly described as just a brief pinch or a sensation of mild internal pressure. It is absolutely not an agonizing surgical event.
That is wild. And because the material is autologous, meaning it's harvested directly from your own veins, the risk of allergic reaction or tissue rejection is practically non-existent.
Exactly. Plus, there's no surgical incision requiring sutures, and there's no general anesthesia to recover from.
Which means the recovery timeline is practically instantaneous. You just leave the clinic, drive yourself home, and go about your normal day.
Pretty much. Providers typically advise abstaining from sexual activity for about 24 to 48 hours, just to allow the volume of the injected fluid to integrate into the tissue.
But there's no forced bed rest or anything.
None at all. And the biological timeline for the actual results is equally distinct. Clinical guidelines establish a 3 days, 3 weeks, 3 months expectation.
Right, the 3-day mark is fascinating. Many women report a sudden spike in sensitivity right away.
They do, but the literature notes this isn't the growth factors working yet.
Right, it's just localized hyperazemia, basically an immediate physical rush of blood and inflammation responding to the mechanical action of the injection itself.
Exactly. The true regenerative cellular work takes much longer. The actual biological shift begins around the 3-week mark.
Because that's the time required for the VEGF and other factors to stimulate the fibroblasts and build the new capillary beds.
Yes. That's when patients start experiencing genuine, sustainable improvements in natural lubrication and sensory nerve response.
And then by 3 months, the literature notes that's when the results really peak. The new collagen matrix is finally mature and fully integrated.
And those benefits can persist for up to 14 to 18 months.
Wow. At which point, I assume the newly formed tissue will eventually begin to age at a normal biological rate again.
Right, so patients might consider a maintenance treatment eventually to sustain that localized cell signaling.
Okay, but Hearing about all this rebuilding raises an obvious conflict, especially for anyone going through perimenopause or menopause.
What do you mean?
Well, standard care says systemic estrogen deficiency causes vaginal atrophy and that loss of sensation. So hormone replacement therapy, or HRT, should be the primary fix.
Ah, right.
If you're already on an estrogen patch or using a localized estrido cream, it feels like injecting PRP is kind of redundant. Does the O shot just bypass the need for hormones entirely?
Oh, no, it definitely does not replace hormones. Understanding the distinction between systemic fuel and structural repair is vital here.
Okay, break that down for us.
Estrogen acts as the systemic fuel that keeps the cellular machinery of the vaginal and clitoral tissue running. If a patient has a true systemic hormone deficiency, HRT is absolutely necessary to restore that baseline chemical balance.
But if someone has been estrogen deficient for a decade, the physical architecture of that tissue had already degraded, right?
Exactly. The capillary beds have retreated, the collagen matrix has collapsed, the nerve endings have thinned.
So pouring high-octane estrogen fuel back into a broken engine won't make the car run perfectly.
That's a great way to look at it. HRT provides the chemical fuel, but the PRP acts as the localized mechanical repair. It rebuilds the physical structure that the hormones can then successfully maintain.
Oh, so they're completely synergistic therapies.
They are. PRP belongs to a broader regenerative toolkit that addresses physical tissue degradation. And when we look at the clinical applications of that physical repair, restoring sexual sensation is really only a fraction of what this biological mechanism can achieve.
Yeah, the clinical sources highlight some massive applications for PRP and intimate health that honestly have nothing to do with sexual enhancement.
Right. The most prominent application is utilizing these growth factors to treat stress urinary incontinence, or SUI.
Which affects millions of women. It typically manifests as localized leakage during moments of intra-abdominal pressure, like coughing, sneezing, or exercising.
And it happens because the anterior vaginal wall and the pelvic floor tissues that physically support the urethra weaken and lose their structural elasticity.
But the mechanics of treating this with PRP are incredibly straightforward, right?
They really are. Providers just inject the platelet-rich plasma directly into the anterior vaginal wall, specifically targeting the periurethral space.
And the subsequent collagen and elastin production physically thickens and tightens that supporting tissue.
Exactly. It essentially builds a biological scaffolding under the urethra, restoring the structural integrity needed to prevent leakage.
I mean, the ability to regenerate structural support without relying on invasive synthetic mesh surgeries represents a massive leap forward in gynecological care.
It's revolutionary.
Yeah.
And we see a similarly profound application in the treatment of lichen sclerosis.
Right. For those who aren't familiar, lichen sclerosis is a chronic, severely debilitating inflammatory skin condition.
It's awful. It attacks the genital region, creating severe white plaques, agonizing itching, and really aggressive tissue scarring.
And that scarring can literally fuse anatomical structures together, making intercourse excruciatingly painful, a condition known as dyspareunia.
Yes. And standard dermatological care relies heavily on ultra-potent topical corticosteroids.
Which are highly effective at suppressing the immune response and halting the active inflammation, right?
They are, but they do absolutely nothing to reverse the physical scarring that has already occurred. In fact, long-term steroid use can further thin the tissue.
Which is where the specific biochemistry of the PRP is showing such unprecedented results.
Exactly. When the plasma is injected directly into those scarred sclerotic plaques, the transforming growth factor beta goes to work.
It actively breaks down the dense fibrotic tissue, the scars, and signals the local stem cells to regenerate healthy, elastic skin cells.
And it restores normal nerve function in areas that traditional medicine had basically written off as permanently damaged.
It's amazing. When you evaluate the full spectrum of these applications, reversing the debilitating scarring of lichen sclerosis, rebuilding the periurethral support to cure incontinence, and restoring the dense neurovascular networks of the clitoris to eliminate dyspareunia.
The narrative surrounding the O-shot changes completely.
It really does. It moves out of the realm of luxury wellness enhancement and becomes this foundational tool for restoring basic physiological function and quality of life.
And, the psychological toll of losing that physiological function cannot be overstated.
Definitely. Whether it's the silent distress of struggling to reach climax in your 30s or the anxiety of navigating painful intercourse and incontinence in your 60s, these conditions create profound disconnections.
They strain intimate relationships and force women to quietly accept a diminished version of their physical selves.
Right. But the underlying message across all these clinical journals and data points is that these dysfunctions are biological hardware problems. And we now possess the localized software updates to fix them.
We have transitioned into an era where cellular regeneration is a tangible, accessible clinical tool. We really no longer have to manage the symptoms of tissue degradation. We can instruct the body to actively reverse it.
So, to bring all these sources together, the O shot, or localized vaginal PRP, leverages the concentrated growth factors in a patient's own blood to stimulate angiogenesis, rebuild collagen scaffolding, and regenerate sensory nerve endings.
And while regulatory bodies rightly demand larger, standardized trials to parse out trademark protocols from generic applications, the underlying biochemistry is sound.
The clinical reality is that the day surgery revolution has made this a 45-minute, highly tolerable outpatient procedure.
It doesn't replace the systemic balance provided by hormone therapy, but it serves as a powerful adjunctive tool to structurally repair tissue damage caused by aging, childbirth, or chronic inflammation.
The evidence points to a biological mechanism that genuinely improves clitoral sensation, thickens the anterior vaginal wall, and offers targeted relief for conditions that millions of women endure in silence.
This deep dive really forces us to examine a much larger implication about the trajectory of modern medicine, too.
How so?
Well, we have spent over a century building a healthcare system entirely dependent on synthesizing external chemical compounds to treat our ailments.
Right, relying on pharmaceutical giants to manufacture the solutions to our biological decay.
But if the raw material required to cure incontinence, break down severe fibrotic scarring, and regenerate entire neurovascular network is already flowing through our own veins, it completely disrupts that model.
Oh, wow.
Yeah. If autologous medicine using the patient as their own pharmacy continues to prove this effective across different medical disciplines, it raises a massive question. Will the future of medical innovation eventually bypass the pharmaceutical industry entirely?
That is an incredible prospect to leave you with. If the ultimate cure for our localized physical decline isn't going to be engineered in a lab, but simply harvested and distilled from our own biology, it completely rewrites the future of how we age. Thank you for joining us on this deep dive. Keep examining the evidence, keep questioning the systems we rely on, and keep exploring the incredible science of your own biology. Until next time.